So my case is neuromyelitis optica, which is a severe inflammatory demyelinating disease that preferentially affects the optic nerves in the spinal cord and involves severe bilateral simultaneous optic neuritis, longitudinally extensive transverse myelitis and area postrema syndrome, with majority of the patients suffering a relapsing course even with immunosuppressive and immunomodulatory treatment. So in our case, a 26-year-old female came with the chief complaints of diminution of vision in the left eye since last 1.5 months, which was preceded by neck pain, head reeling, vomiting and generalized weakness. She had a history of use of contraceptive pills for the last 2 years, which she stopped 6 months back. She became pregnant 2 months back, which was followed by spontaneous abortion 15 days back. On examination, right eye was within normal limits, and in left eye, the best corrected visual acuity was found to be counting fingers close to face and near vision of less than N36 with a grade 3 RAPT. A strabismic workup was done which showed 15-degree left exotropia with modified Krimsky test of 15 prismadiopters of left exotropia. We saw that the fundus was within normal limits, with which we came to a provisional diagnosis of left eye retrobulbar neuritis and acquired exotropia. Investigations were sent in which contrast enhanced MRI brain plus orbit showed left optic nerve thickening with T2 hyperintensities and increased post contrast enhancement, and contrast enhanced MRI spine shows subtle patchy areas of hyperintensity involving the cervical spinal cords from C2 to C4 segments. Lab investigations were sent in which we saw that NMO aquaporin 4 antibody was found to be positive, MOG was negative and APLA was negative. VEP showed prolonged latency in left eye with normal amplitude. With this, we came to a final diagnosis of left eye retrobulbar neuritis, which is seropositive NMOSD with left eye sensory exotropia. Intervention: 3 doses of injection IVMP was given under the physician's guidance, which was followed by oral steroids for 11 days along with oral calcium supplements and PPIs, but no significant improvement was seen in vision and color vision. So neurological consultation was done and the patient was started on IV immunoglobulins followed by rituximab. With this, we came to an outcome of best corrected visual acuity of counting finger 2 meters in the left eye with grade 3 RAPD. The patient is on regular follow-up with neurologist and ophthalmologist and is being given monthly injectable rituximab. This disease is characterized by a specific IgG antibody against astrocytic aquaporin 4 water channels in most of the cases, and its intensity increases the disease activity in maternal and fetal outcomes patients during pregnancy. Neuro-ophthalmological examinations of OCPs include 6 cranial nerve palsies, parietal syndrome, hemianopsia, and papilledema. Vascular complications include CRVO, CRAO, aneurysms, macular edema, and acute ischemic optic neuropathy. Isolated cases of transverse myelitis is reported after long-term uses of OCPs. Pathophysiology includes the fetoplacental unit synthesizes Th2 cytokines that causes a downregulation of maternal cytokines, increases of humoral immunity. With higher estrogen levels, there is a development of self-reactive peripheral B cells that causes increased antibody production, and that causes placental inflammation causing preeclampsia, abortions and stillbirths. It is a relapsing central nervous disease which occur during pregnancy, in early postpartum period or during lactational phases. Delayed diagnosis yield fatal outcomes. Unlike typical demyelinating optic neuritis, majority of the patient require early immunosuppressive therapy to minimize the long-term disability, and recurrences and relapses are common. In spite of aggressive treatment, visual prognosis is poor in most of the cases. Thank you.
Anything different in this particular case?
So this was a unilateral case that came to us with a history of OCP use. With pregnancy and lactating mothers coming with optic neuritis is still seen in the literature, but having OCPs might have caused this disease.
Possible, difficult to prove.
Yes.
it can be something which is incidental
It's
also.
coincidental, not
Uh,
necessarily.
But yes, studies are being done to find the correlation between the hormonal therapy and NMOSD. So there have been various studies in the literature, though they are still exploring what is the exact pathology, as you have said. So it was a well documented case and an interesting one. But yes, it can be coincidental and hard to prove, as sir has said.
One question I wanted to ask, how long did you follow, means steroid was given to this patient, did you follow the normal regimen or something different
Yes,
regimen
ma'am,
was there?
normal regimen was followed. That is 3 days of 1 gram IVMP followed by 11 days of oral steroid, 1 gram per
No,
kg.
did you, means it is a correlation between you and the ophthalmologist and the neurologist, okay? So once they have diagnosed, whether I'm asking you specifically, was it only for 11 days or they did more steroid was used in this case?
Ma'am, after that steroid was not used, the patient was shifted to immunoglobulins. And
So
then,
immediately they gave them immunoglobulins? No, that
yes, ma'am, neurologist opinion, they like the
started
patient was,
immediately with
yes, ma'am.
immunoglobulins.
We
Okay.
didn't see any visual improvement, so the patient was referred and they started with IV
Now, what does the
immunoglobulins.
literature says actually? If you go back and see the literature of the studies, so can you, since you have read, I'm asking you, how long should the steroids be given, and then is there a cutoff level, or when do we see them, and what do we see them to start with immunosuppressives? As a postgraduate student, I'm asking you this.
Ma'am, according to the protocol, 3 days of high dose IVMP and then that protocol.
Use was something atypical optic neuritis you are dealing with.
Yes, ma'am.
Yeah. So how long do we see, is visual acuity the criteria or some other things is a criteria to change over to immunosuppressive?
Ma'am, improvement in the color vision also we take into account.
Okay.